Welcome friends. Now let's look into another important topic in medicine or a system in medicine that we know as the central nervous system. The central nervous system is a topic which is commonly not studied by any student. That is the full form of CNS which I know. And it's a common nervous scare also for any graduate or postgraduate who attends the medicine clinics. But now can we study it? Yes. It's an old proverb that neuro is like maths. If you understand maths and the equations, the topic of neurology are very easily understood. And as you can see, this is the JCB machine that we have with us. And whenever the JCB tries to dig out something from the ground, there's a lot of people surrounding it. So whenever there is a neuro case in the ward, there are many doctors trying to understand it, but they have not studied it, so they are scared of him. But let's take out some time to understand and study this topic of neurology. To start with, I'll start with the very first and a very basic one topic to start, which we see in our daily rounds in the ward and the OPD as well, which you know as a seizure disorder. Okay. Now please do remember this. The word seizure is actually being derived from a Greek word sakai. And don't forget, this Greek word sakai means to take possession of. Correct? So that means I'm not under my own control. Someone is trying to control me from outside, or someone has taken a control of me is the Greek word sakai, from which the word seizure has been picked up from. But the medical definition is very important to understand. It is defined to me as a paroxysmal event due to hypersynchronous central nervous system discharges. Correct? So what do you find as a proper definition of the word seizure now medically? Let me break the words and find a good meaning out of each word. The word paroxysmal means to me as all of a sudden. Hyper means more, and the word synchronous stands for together, from a part of nervous system which is known as the central nervous system. Now if I anatomically see the central nervous system, it is made up of two things. One thing which lies above is a cortex, and below is the spinal cord that we have. Now to be very precise, both of them being a part of CNS, yes, but seizure often originates from the cortex. It doesn't originate from the spinal cord. That's very important thing. Now if you know the cortex histologically, it is made up of many cell layers, and there is an important cell layer in the cortex which will often give rise to a seizure activity, that is known as the pyramidal cell layer. So we got a motor or a pyramidal cell layer in the cortex built up there, which is going to give rise to a seizure activity. So let me rewind this all again. Seizure is all of a sudden event, paroxysmal, when discharges originate from the central nervous system, from the pyramidal cell layer. And all of the discharges are in excess, hyper, and most of them they act together in synchrony. So that's a basic medical definition of the word seizure. Now, you might have also heard this term in your day-to-day clinical practice, epilepsy. As a layman term, in my graduation, I used to always think that epilepsy means recurrent seizure. No, there's a proper definition being pronounced for it. It is defined to me as two or more than two unprovoked seizure that we have. Correct? There is no provoking factor, and there are two or more than two unprovoked seizure that we have is defined as the word epilepsy. So look at this. For example, you attend a patient in the hospital with a low blood sugar, hypoglycemia, or maybe a low sodium, hyponatremia. Both of them, when I look at, are correctable causes, and the seizure in both the condition is always seen to be as a provoked seizure. But to define it as epilepsy, it has to be unprovoked seizure. Two or more than two is enough to define epilepsy. So seizure on one end and epilepsy on the other end, okay, are not the same. Just for the journal examination example nowadays, a patient who came to me with sore throat infection is not a COVID infection, correct? Not every patient of sore throat is a corona or a COVID case. We need to have some qualification to call it as a COVID infection, and it can be a simple viral sore throat or a simple flu-like infection. Okay, so overdiagnosing sore throat as COVID and underdiagnosing COVID is a harmful thing for the society nowadays. So please remember, what happens once is a seizure, what happens recurrently is epilepsy, but it has to be two or more than two unprovoked seizure. Now we'll try to look into this concept. Why does the seizure actually happen? What is the mechanism of epileptogenesis that we have? To understand this, we got two neurotransmitters in the brain working all the time. One happens to be the glutamate, and the second one that we have with us is the GABA. So please do remember this. Glutamagic activity to the brain is always found to be excitatory, and GABAergic activity towards the brain is always found to be inhibitory. Remember this. But how is glutamate excitatory? Now that's important. To understand this, I'll make this as a cell of the brain, the same cell where the seizure originated from, maybe the pyramidal cell layer or a simple neuronal cell. Now what will happen first? This neurotransmitter that we know as glutamate is going to act on this neuronal cell. As a result, the action of glutamate over here is going to open up certain kinds of channels. A very important channel is for a cation which I know as the calcium. So, okay, I'll just draw this arrow clearly. So it's a calcium influx which occurs by the effect of glutamate on any kind of a neuronal cell. Now, after the calcium influx, there is going to be a rapid influx of another cation into the neuronal cell, which I know as the sodium. Now you know this. Both of them are cation. They are positively charged. That means the inner membrane is going to charge itself as a positive thing. Now if you know the very basic concept, the resting membrane potential RMP is always standing as negative, correct? If I want to make the cell membrane positive, I'm going to depolarize that particular cell membrane, correct? So basic physiology tells me the resting stage is always negative inside. If I charge it positive, it is going to fire and depolarize. And now this positive charge will give rise to a seizure activity. Now I have to stop the seizure. To stop it, an anion is going to enter the neuronal cell, which I know as a chloride. And the chloride influx will automatically stop the seizure activity. But very important thing, to make the chloride enter the cell, we got a neurotransmitter which happens to be an inhibitory one, which is nothing but GABA. So GABA causes an influx of chloride. To stop the seizure, it inhibits it, while glutamate excites it or starts it. Now the basic concept should be very clear in your mind, that whenever we find the patient with seizure, there is something lacking in the brain. That is the GABA. So if there is less of inhibition by GABA, automatically there is going to be more stimulation by glutamate. And what are we going to end with? Is seizure. Let me take this topic out from your pharma books. If you read in pharmacology, there are drugs to treat epilepsy. And those drugs have come into one broader range as what? Anti-epileptic drugs, AED. If you know the mechanism of action of these drugs, they're going to block what? Either the calcium or the sodium channel. So the blockage of the calcium or the sodium channel brought about by these anti-epileptic drugs, which is going to cause or rather prevent or rather treat a patient or seizure. It's very simple. Now moving forward into this is a basic physiology or maybe a part of pharmacology also. Now let's move into the hardcore medicine. What we need to know in medicine is this. How are we going to classify a particular disorder as a seizure disorder? Correct? how am I going to classify a patient with seizure? To understand this, I'll make two diagrams, which is nothing but the cortex of the brain. Now the cortex is going to have two kinds of lesions inside it. One lesion is at a point here and another one is all over here. So we find two kinds of lesions in the brain. One is all alone, known as a discrete lesion. Other one is all over, which I know very well as a diffuse lesion. Now how is it going to impact the patient? Look at this. Whenever a discrete lesion is going to fire, only one body part will have the seizure activity. While look at this anatomically, whenever a diffuse lesion is going to fire, the whole body is going to show me a seizure activity. So let me classify it. This happens only in one part of the body, so it is defined as focal, while the other one happens all over the body, so it is defined as the generalized seizure. So when I broadly classify seizure disorder, it's focal or generalized in two types. Now another name which we had in our pharma books and in our older medicine literature was partial. So wherever we were using the word partial seizure, remember this, we are now using the word as focal seizure. Somewhere I've seen in the literature and all the textbook, every 5 years they keep on changing the names of these kind of seizure disorder. The meaning is still the same, don't worry. Now very important thing, what is this discrete lesion when I look at? This discrete lesion is nothing but a structural abnormality in the brain. So any kind of a structural abnormality in the brain, for example, it can be a brain tumor, one. It could be a brain abscess, second one. So any abscess or any kind of a tumor inside the brain behaves like a structure abnormality, and that structure abnormality will create a discrete lesion and result in the patient with what? A focal seizure. But important thing, generalized seizure, right? Why will a generalized seizure at all happen to anyone? There are three basic reasons for that. Either the patient has been exposed to certain kind of drugs, or could be certain kind of toxins, and third most important not to neglect is metabolic. Correct? Now what are these metabolic kind of things? For example, could be a common disorder like hypoglycemia. As I earlier told you, it can provoke seizure, but what kind of seizure would happen is a generalized seizure. Another one, don't forget, is hyponatremia, low sodium. Now this has been an old MCQ, write it down. The most common biochemical abnormality, remember this, the most common biochemical abnormality precipitating a seizure disorder in the patient is nothing but your hyponatremia, low sodium. But our intelligent student came back and asked me, sir, you told us in the beginning of the class itself that the sodium has to enter the neuronal cell to cause the active depolarization inside it. But today I've got low sodium in my blood. Now look at this. The sodium is less outside the cell, extracellular fluid. Relatively, I'm going to find more sodium inside the cell, which I know as the intracellular fluid. Now look at this concept. If less sodium more sodium inside the cell, as the nature tells me, water as a solvent is always going to move from a hypo to a hypertonic gradient. Now look at this. If you have more sodium, the osmolarity is going to rise. So it's going to be more hypertonic inside the cell. And now when the water enters the brain cell, what do you get? A lot of water inside the brain cell, we get what? Cerebral edema. And this edema is going to be what? A diffuse edema. And that diffuse edema is enough to cause seizure. What kind? Generalized seizure. Simple. Just an afterthought on this. Hypo and hyperkalemia. Write it down. Hypo and hyperkalemia. Two another important electrolyte abnormalities will not cause seizure. So as the saying goes, the sodium doesn't affect the heart directly and the potassium doesn't affect the brain directly. And it may be like this: the sodium hits the brain and potassium stabs the heart. So in clinical practice, if you come across a patient of hypo or hypernatremia, don't expect any ECG abnormality. You can have some EEG abnormalities, of course. And in the OPD or ward, you find a patient of hyper and hyperkalemia. Expect an ECG abnormality, not an EEG abnormality in them. Okay. Now, another very important thing, as I was stressing about this, drugs. You should know these drugs. There are certain kind of drugs in clinical practice that we often use in day-to-day practice, and exposure to these drugs is going to create a seizure. Now, what are those drugs? Write them down. Drugs precipitating seizure disorder. Correct? What are the drugs which are going to precipitate a seizure disorder? There are many A's in them. The very first one in the A, or rather I can use the word anti in them just to remember them better. Now the very first anti is the antibiotics, which are acting against the active bacteria. Now two antibiotics I remember. One is the beta-lactam and second one is a group very famous, quinones. The Oflox, Ciproflox, Catty, Moxie, all of them. If you go back into your ward, you might have seen them also. People come with abdominal pain, sore throat, or infection. It's a common tendency to write Ciproflox or Oflox. And now the patient throws a seizure. He might be susceptible to seizure. Yes, he might be having a past history of seizure. But exposure to these group of antibiotics is nothing going to do good for him. It's going to do bad for him. It is going to precipitate seizure in the patient. Just another anti, very important, is the antiviral groups. In the antiviral, we have two with me. One is the acyclovir and another one is the ganciclovir. So these are the two antivirals which are going to cause a seizure in the patient, or rather precipitate. Then in the anti group, we have with us the antimalarials. The antimalarial that we have with us is number one, the chloroquine, and of course your mefloquine. Okay, so be careful with them next time when you use them. Fourth could be the anti-cancer drugs, okay, which can be a sort of a agent which I know as alkylating agent. So some alkali media is very well known to suppress the tumor cells. So some alkylating agent which are grouped under the anti-cancer or chemotherapeutic agent could be a cause for precipitating seizure. Number one is the busulfan and other one is the chlorambucil. Okay, remember the names. Then you can use as a term, can be anti or rather anti-analgesic, or I can use this word as, I can put it separate, it's better. Certain kind of anesthetic agent. Now I'll put the word anti out from there. Anesthetic agents, some anesthetic agents and exposure to it will create a seizure. What are they? Very commonly asked question in pharmac also, in this your anesthesia medicine also: mepridine, fentanyl, tramadol, and local anesthetic. Very common scenario. I have seen this patient once. I can never forget him. There was a case of head injury and we were just trying to suture the wound. And of course you inject a local anesthetic, and somewhere it was a facial injury here. We just injected the local anesthetic and it went into the circulation. And in a shorter span of time we found him throwing seizure. And don't forget this very commonly used analgesic, tramadol, is another notorious drug used in the surgery department. That's why from surgery patient comes into medicine, because now he's thrown a seizure, right? So there is no active surgical intervention at that point for them. Okay. Now don't forget something about the drugs. Sorry, I not mentioned the word drugs here. It's better if I mention it as toxins. Now there are two things in the toxin. Either we are using it on daily basis, which I know as the abuse part, or it could be the withdrawal of the toxin that we use. So it can be two parts. Either it can be abuse or it could be a withdrawal of the toxin. Now don't forget, in the abuse we have got two things. Amphetamine, and the second one happens to be the cocaine. Now very commonly scenario in young people in northern India, there are a lot of cocaine abusers there, and they go through a season, and when we go back to the history, they are using it on daily basis. Now the withdrawal part. Not to forget alcohol withdrawal, the topmost in it. Alcohol, ethanol, the generic name of the drug alcohol. Okay. Second one is the baclofen that we use. And then even the barbiturate withdrawal has been labeled as a cause. And zolpidem, yes. I've seen this in the youngsters nowadays. They take this drug left and right. They stop it. They throw a seizure. So zolpidem is a sedative, and its withdrawal will precipitate a seizure. Don't forget this. Although it's a drug, but I'll consider it always as a toxin, not a good thing. So that's all about the basic classification. How do we see it as focal or generalized? Now moving into the further classification. Yes. How do we classify focal seizure? Remember this. Focal seizure has been classified on this phenomena known as LOC. LOC stands for line of control for a soldier. But LOC, for me as a soldier, nowadays a COVID soldier, it's loss of consciousness. Correct. The word consciousness means staying in contact with the environment, or maybe awareness to know what's happening around you, and above all, cognition. Now I'll explain this in a very simple example. If you're conscious, you're awake, you're aware, you're in contact with me. If you're unconscious, you're not aware, you're not in contact with me. Neither do you understand what I'm talking about. Like you go to sleep, you become unconscious, right? And the best place to sleep is the classroom. Now the problem is in these online classes, your bedroom has become classroom. Now, while attending an online class, you want to sleep. Will you go back to the bedroom or sleep there? No, you sleep here only. But how will you sleep? You'll always sleep with eyes open. So it is a very fair possibility that I lose consciousness with eyes open. At that moment, I lose the awareness of what's happening around me. And most important, what I'm teaching you, you don't understand that. Your understanding part is lost, known as cognition. So remember this. LOC present or LOC absent. I'll make this again clear. Why I'm putting this as equal to, because consciousness means awareness, consciousness means cognition. All three are different words in grammar, but at the end of the day, they mean the same medically for me. Now LOC is present, LOC is absent. There are two things with me. If loss of consciousness is present, there is a loss of awareness that we find. That is known as focal seizure with impaired awareness. Correct? While one patient who doesn't have loss of consciousness is known to me as a focal seizure with intact awareness. Two things happen with me. Apart from this, there's an old term which is being used now, is dyscognitive and non-dyscognitive. Correct? So there's a problem in cognition, that is dysfunction in cognition known as dyscognitive. There's no problem in cognition, that is known as non-dyscognitive. There's another two names given to it as complex and simple. Now I'm writing like this, I'll tell you why. The word was partial seizure, correct? One patient of partial seizure who came with loss of consciousness was known as complex partial seizure. One who did not come with it is known as simple partial seizure. But if you remember, I've talked about this earlier also. Partial seizure is now known as what? Focal seizure. So, focal seizure with loss of consciousness was known as dyscognitive. Without loss of consciousness was known as non-dyscognitive. But what has happened now? They put two new names for it. Focal seizure with loss of consciousness known as impaired awareness. Without loss of consciousness is known as intact awareness. See, I'm putting an arrow and equivalent sign also to them. So complex partial, simple partial were the old names, but now the recent literature writes them as focal seizure with impaired awareness, focal seizure with intact awareness. Moral of the story, remember this way. A patient of focal seizure who is not in contact with me while during the episode of seizure is known as focal seizure with impaired awareness. While a patient of focal seizure knows what's happening and comes to me with a complaint, doctor, my hand is shaking, he is not in any loss of contact with me. That means he's a focal seizure with intact awareness. So we divide focal, or rather focal seizure is classified on the phenomena of LOC. Third type is this. If you see this as a discrete lesion, right? If you see this as a discrete lesion, surrounding the discrete lesion, there is going to be a lot of what? Cerebral edema. So there is a cerebral edema as a part of tissue reaction also around a discrete lesion, but this cerebral edema is not minimal, it's a lot of edema surrounding it. So what happens? Wherever the discrete lesion was sitting, focal seizure happened there. But because of the cerebral edema, which was so massive, the seizure went everywhere. That means initially it's focal and then it becomes generalized. So like the third type with secondary generalization. So it becomes generalized later on, not initially, known as secondary generalization, right? So these are the three basic types. So focal seizure who loses contact with the environment is focal seizure with impaired awareness. Without loss of consciousness is known as intact awareness. The recent name are these, and these two, dyscognitive, non-dyscognitive, complex, simple, all these are old names. Okay, you should just know them. Third, one seizure which was initially focal, but because of a lot of cerebral edema becomes generalized later on, is known as with secondary generalization, right? So that's all about the classification part of focal seizure. Now moving in further, we should know two more things happen in the life of focal seizure. Two more things do happen in their life. One is an episode of Todd's palsy which occurs in focal seizure. And the second episode is an episode of Jacksonian march which happens in a focal seizure. Correct. Now look at this. Todd's palsy. Todd's palsy. The word palsy comes from the Greek language which means paralysis. So just imagine my right upper limb is having a focal seizure. Obviously, the lesion is in the opposite cortex because of the contralateral connections that we have. So my right upper limb shakes in focal seizure. But after that, the limb stops moving. Why? If there was a lesion in the left cortex, it was firing excessively. If I'm excessively working, I'll get tired, I'll take rest. But after rest, I'll recover also, no? So let me write this down. The word Todd's palsy is something which is known as post-ictal paralysis. The word paralysis, weakness of the palsy, and the word ictal stands for seizure. So after the seizure, the weakness in the limb that happens is known as Todd's palsy, post-ictal. Now the word ictal is standing for nothing but your seizure disorder. So seizure is known as ictal phase, okay? So after the ictal movement phase of the seizure, the limb goes weak, is known as Todd's palsy. Now as I was talking about, if I'm working too much, I'll get tired, I'll go to sleep. But anyway, I'm going to get up. That means this phenomena will also get back to normal. It is self-recoverable. That means I need not chase it, I need not do some good kind of a treatment for it. So if a patient of torch palsy after a focus seizure comes to you, just wait and watch. Reassess him in few hours or few minutes, because most likely they're going to improve upon. Then we have another important event, Jacksonian march. Okay. Now imagine this as a lower limb of the patient. LL stands for the lower limb. The seizure starts in the toes, go to the foot, move to the leg, or it starts in the leg, go to the toes. That means the onset of the seizure is distal and then it goes proximal. Or it can be other way around. Just imagine this. Patient's upper limb, I'm making the upper limb now. It could start in the fingers, go to the hand, go to the forearm and then the arm. That means the seizure in the upper limb which could happen to start distal and then go proximal. So just imagine a person standing right in front of you and his finger starts flickering, hand movement, forearm and then the shoulder. Or maybe his leg starts moving like this and keeps on going up. So he's trying to do a breakdance kind of a movement. If you remember, the father of breakdance was nothing but Michael Jackson. So just a simile to remember it is known as Jacksonian march. So remember this. Jacksonian march is a appearance of focus seizure in a particular limb. So in a limb, if the focus seizure happens to start distal and move proximal or other way around is known as Jacksonian march. Like just journal example. If a history comes like this, a patient has come to you with the seizure starting being noted in the foot muscles. That means the fingers or the toes on the foot region are shown to have seizure activity first. After that, the foot muscle gets involved. Okay. After that, the leg gets involved and then the thigh gets involved. If this kind of an activity is seen, this is nothing but your Jacksonian march activity. But on the other side, if the examiner puts you like this, in the patient, upper limb is involved, followed by the lower limb, followed by the upper limb, and then the lower limb. Maybe I can take this as the left side, then I can take this as the right side. So this is not Jacksonian march. I hope you remember. This is what? It started in one point and the whole body later on get involved because of it. So it is known as what? Focal seizure with what? Secondary generalization. So you need to differ the two events. If a limb only, that means only the lower limb is involved, distal to proximal, proximal to distal, or it can be even the upper limb. That is Jacksonian march. That is Jacksonian march. But in a patient we find suddenly one part of the body is involved in this pattern. It is known as focal seizure with secondary generalization. Okay. Remember this old fact. In absence seizure, to define it, the loss of consciousness is present in the patient. Okay. And tone is normal. The posture of the patient is well maintained. So don't confuse this thing. The word posture is well maintained in the patient. And don't forget this. This loss of consciousness in the patient is usually a abrupt onset kind of a thing. And second important thing, the duration of it is less than 30 seconds. So the duration is very short, one thing, and it's all of a sudden which happens in the patient, abrupt onset. Apart from this, don't forget, in these patients there are subtle motor signs which are seen. Now the word subtle basically means minor. So there are minor motor signs which are seen in the patient. Yes, subtle. I'll explain them what are they later on. Apart from this, aura, most important, aura. Aura, which is something seen in the patient prior to the onset of seizure, is usually absent. It's not seen with the patient. And of course, after the seizure, we know about them. There is no post-ictal confusion seen. So after the seizure, there is no post-ictal confusion, and prior to seizure, aura that we see is usually missing in them. What is aura? Don't worry, I'll explain that also later on in a particular disorder. And most important, when we want to diagnose them at time, we go in for electroencephalogram. The brother of electrocardiogram for the brain is electroencephalogram, EEG. Now, EEG is something which we find very typical in them. Don't forget the finding. It's a very, very important topic. In the patient, we find bilateral 2 to 4 hertz spike and wave which are seen with the patient. So there are some spike and wave which are seen in the patient brain on EEG. And of course, they're seen on both the sides of the brain, they're bilateral. But most important, they are precipitated by a maneuver which you know as hyperventilation. So we tell our patient to breathe rapidly, and hyperventilating for just a moment of 1 to 3 minutes time. We find in the patient that on the EEG we find these kind of pattern, the spike and wave. Okay. Now just imagine this. How would it all look like? A spike is a deflection maybe like this, and a wave could go like this. And now don't imagine this as a ECG, PQRST. No. Someone told me, sir, we'll make the P wave, Q wave, ST wave. No. I'm just trying to compare it, not with the ECG, please. So if I see a deflection like this happening, it is the spike, and this is a wave. So these kind of deflections could be seen on the EEG, which are known as a spike and wave pattern, right? Now, the wave, yeah, someone pointed out rightly. The wave may have a pointed tip on the top and might resemble a dome, yes, like this. So some of the authors have written this wave also as a dome. Please remember this. The wave and the dome are the same thing. So that's a very old MCQ being recurrently asked, that spike and dome pattern on the EEG is something which is highly suggestive of absence seizure. On what? Hyperventilation. Now pay some attention, because every topic which I take out in neuro, I'll always give you a clinical scenario. Listen to me patiently. A very typical history which has been mentioned in your pediatric textbook also. Absence seizure, as we saw, was petit mal epilepsy. The onset occurred in the bracket of 4 to 8 years of age. So he's a kid who goes to the school and in elementary classes, 4 to 8 years of age, and maybe nursery, KG, first standard, right? And it's a school teacher who attends the child in the school and complains it to the parent in that great event. I hope you have also gone for such event known as parent teacher meeting. Don't write this. PTM. In school. Thank God in medical college we never had such events. We only had convocations. Good. Now the teacher tells the parents that your child is not attentive in my class. He's not getting good marks in exam and often getting distracted. And suddenly in the classroom, whenever I ask him a doubt, he starts hyperventilating because he doesn't know the answer. On an hyperventilation, it suddenly precipitates. Or instead of answering me, your kid in the class just looks at me, or rather stares at me. So look at this. This loss of contact will give the patient a very typical stare or a blank look. Correct. So the child who is being questioned for any kind of a question, and now the child starts hyperventilating because he doesn't know the answer and gives a stare or a blank look. On top of it, that very child is blinking his eye. He's doing some eye blinking, lip smacking, kind of a thing. So just imagine a teacher asked a student something, a doubt or some question. You answer me. The child gets frightened, he hyperventilates. Instead of answering the teacher, he just keeps on looking at the teacher. When the teacher goes near the kid, he's doing eye blinking, lip smacking, subtle motor signs. And all of this drama will end up in just 30 seconds time. In a very short time, all of this will end up. And when the child wakes up from that event, he looks at everyone around him and tells them, what happened? All is well, all is well, all is well. Why all is well? Because in these patients, there is absolutely no post-ictal confusion. So that's a very important thing. Remember them, they are physically present but mentally absent for a very brief or a short time. That's why the word absence came for them. Okay. The lip smacking, you eat jalebi or some good ice cream, and it sticks to your lips, and you, yeah, that's known as lip smacking. Okay. Someone wrote it, the basically is a scene of our Viva. I agree. I know my scene. I was roll number one in my college all throughout my life. So my Viva was a double blind trial every time. I never knew the subject and the examiner never knew me. Okay. Atypical absence seizure. Atypical absence seizure, right. Now, atypical absence is something which is different from the typical one. It's not the routine, it's something different known as the word atypical. Now, what is the thing that we find atypical in here? In atypical absence seizure, we find with them the loss of consciousness is C, LOC, which is less abrupt in onset. One thing. Secondly, very, very important, it is of more duration. So one thing happens with them in atypical people, they are different people, they are abnormal people. First thing which happens is that they have got loss of consciousness, which is less abrupt in onset and more duration. Please note this down. These patients also show low IQ or mental retardation. So low IQ or mental retardation is often seen with these patients. Okay. Along with that, these patients are also known to have some kind of structural abnormalities. Structural abnormalities in the brain are quite often seen in them. On, of course, the neuroimaging part that we do. Now, you might question me, sir, what kind of structural abnormality? There are very few patients that we have documented with this disease. There is no specific kind of a lesion in the brain that you find in them. It may be a diffuse kind of a lesion, okay? Most important to diagnose them also, we require the electroencephalogram or the EEG. Now, EEG will show in these patients less than 2.5 Hertz spike and wave. Now, look at the word again, spike and wave is back again. But the frequency which we wrote down together in absence was 2 to 4 Hertz. Now the frequency here is less than 2.5 Hertz spike and wave. Okay. And don't forget a very, very important point in these patients. They are often or rather commonly resistant to the medical line of therapy that we know. The anti-epileptic drugs, which I know as the AED. So the anti-epileptic drugs that we use for medical line of therapy, they don't respond to them so well. Okay. Yeah, how much duration? It can be in minutes also. There's nothing fixed on it. Can absence seizure of childhood continue in adolescent? Good point. Good point asked. Can absence seizure in childhood 4 to 8 years of age, can it continue till adolescence? Okay, a genuine doubt has come in. I'll answer you. See, they found in studies that around, go back to the absence seizure and write 60 to 70%. Go back to the absence seizure and write there. 60 to 70% of absence seizure patients happen to have a spontaneous remission. Spontaneous remission by 18 years of age. So we find a spontaneous remission kind of a thing happening in them. Okay. And by 18 years of age, not 12. Okay, not 12. By 18, I've seen them. I've seen many patients of this disorder. And I found them by 18 years of age, most of them, they become normal. They don't require treatment. Another quick point, I like to write it here. In absence seizure, 20 to 40% of these patients are often seen to have a family history of seizure disorder. See, whenever you take a history, you always go into the family history, and especially in epileptic patients, always make it a point to know it. Ask the patient, yes, is any other family member in your family suffering with this kind of a disorder, right? They will always tell you yes. In an absence seizure, 20 to 40% have got a family history positive. So we got quick points on them. They got family history, they got spontaneous remission, they come early in life, they go normal in life also. They don't have aura, they don't have postictal confusion. And there was a brother of his, atypical. See, I'm again telling you again and again, in atypical absence seizure, see what happens is there are not many patients being documented with it. So what age group is commonly affected, young or old, we don't really know. So there are only few points to remember for MCQ. Yeah, atypical can also have subtle motor signs. There's no problem in that. Okay. Right. Now we'll move into another generalized seizure. That's known as the myoclonic seizure. Myoclonic seizure. Myo stands for the word muscle. Correct. Like the word myopathy goes in. And the word clonic stands for a typical jerky movement that we see in a patient. Right? Now I'm teaching in this room of mine that belongs to my kids actually, and suddenly I'm teaching, and in the camera I'm looking at you, and just adjacent to me I see someone's looking at me, and this room is all closed. Obviously I'll not give a blank look. What will happen? I'll give a shivering look like this. What happened? So just imagine this. If I'm having a jerky kind of a movement like this is known as a myoclonic jerk. I'm very sure you must have also experienced it. If at all you are very sleepy and tired and you want to go off to sleep, and suddenly someone wakes you up by touching you. So that kind of a movement that you find in the body is a typical myoclonic jerk. So this kind of a movement or myoclonic seizure, yes, is something which is typically seen in a patient with a jerky movement. So remember this point. A jerky movement presenting in a patient is a myoclonic seizure. So if only one limb is shaking, that is focal. Whole body is shaking, that's generalized. Patient giving me a stare or a blank look will obviously be an absence. And a patient coming to me with this kind of a movement is myoclonic. Okay. Now remember this, the myoclonic seizure whenever happen, okay, could occur due to any kind of a hypoxic injury, any kind of a degenerative pathology, or any kind of a metabolic event. So there are three things that will create a myoclonic seizure very often. One is hypoxia, second is degeneration, and the third phenomena is myoclonic. Okay. I'll ask you a question. A question being framed was this: in a patient with hanging, what kind of seizure would likely be happening? For example, a patient comes to you. Patient comes to you with an episode of partial hanging. Okay. Now, patient might survive and come to you in the hospital emergency room semi-conscious, unconscious, and on top of it, that patient is having a typical kind of a seizure. Now, tell me, in a patient of hanging, what kind of seizure do you expect? Yes, hanging, the ligature mark on the neck will cause always a hypoxic injury in the brain, and that kind of hypoxic injury will result in what? A myoclonic seizure. So these are the questions that we find in the exam hall also. So clinically, orientation is most important nowadays. Now comes another topic, that is juvenile myoclonic epilepsy. Juvenile myoclonic epilepsy, being abbreviated to me as the word JME. Someone in the chat box wrote break. Great people. As a blank screen came. Okay. It will get resolved. It's some hanging. No, it's not hanging. It's going well. Juvenile myoclonic epilepsy, JME, right? Now let us look at the word juvenile first. Why is it known as juvenile myoclonic epilepsy? Because the onset of this problem often occurs in the juvenile age group, and that particular juvenile age group will be early adolescence. So early adolescent part of the life, the juvenile age, we find the onset of this problem very typically. Okay. Now, apart from this, do remember this. Family history again is positive in them. Family history is again positive in these kind of people. And polygenic cause has been attributable to it. There are many genes associated with this problem. So they always say it has to be having a polygenic cause. Okay. So a kind of a polygenic cause has been attributed to it. Many genes are associated with this problem. That's why family history is typically positive in them. Now, we do find in these patients that usually they are of the unknown cause. There is no known etiology for this kind of a problem. In another sense, I want to write this down. Hypoxia, or maybe a degeneration that I know as atrophy, is not seen in these patients. So any kind of hypoxic injury or atrophy is not seen in these patients. So remember this whole point. They are having myoclonic seizure, myoclonic jerks. So remember this, hypoxia and atrophy is typically missing in these patients, not seen in them. Okay. This is of the unknown cause. And why are they known as myoclonic? Because in these patients, bilateral myoclonic jerks are usually seen with them. So these patients, whenever we find them, they happen to have a bilateral myoclonic jerks on presentation, which is typically seen on awakening and often precipitated by two things. One is fatigue and the second one is alcohol. So we find in these patients that fatigue and alcohol are two things which is often going to precipitate it, and they are typically seen on awakening in the morning hours. Along with these things, in these patients, don't forget, loss of consciousness is absent, LOC is absent, and the subtle motor signs which I showed you. If you remember, I've written them also. The eye blinking, the lip smacking. These kind of things are typically missing in these patients, subtle motor signs. Now, have this name clear in your mind. Automatism. Remember this. Automatism is another term applied for subtle motor signs. So minor motor signs, subtle motor signs. Automatism, yes, is another term used for them. So automatism as a word which means subtle motor signs is absent in them. Okay. Apart from it, don't forget this, that majority patients of JME that we know are going to suffer with generalized tonic clonic seizure. Okay, GTCS. Correct. That's the name. Can you tell me another name for GTCS? Another name for GTCS. Can you give me that name for GTCS? Another name, if you know this. Yes. Any answers from your end? I'm looking at the chat box. It's giving me really vertical nystagmus today. Yeah, grand mal epilepsy. Thank God. Grand mal epilepsy. I know you guys are at your home with a mobile phone, a toy in your hand, and whatever comes to your mind, you just type it there. Don't do this. It's a very precious time, and we don't know when the lockdown will end. At least we should study and use this time for Good cause, okay? Please study, most important. Yeah. Otherwise, you won't want to study, don't study. Listen to my song which I have written recently. इसमें तेरा घाटा मेरा कुछ नहीं जाता, बाद में जब क्वेश्चन आता तो सॉल्व नहीं कर पाता, इसमें तेरा घाटा. Okay. Generalized tonic-clonic seizure, GTCS, grand mal epilepsy, another name for it. Now I'm very sure you must have seen a patient at least in the hospital, okay, with an episode of GTCS. Now what happened with the patient? Let's go back and see them. Premonitory symptoms happened with them. Please remember, in patients of GTCS or grand mal epilepsy, some kind of premonitory symptoms happened prior to the onset of seizure. What were they? They were simple kind of an abdominal pain that they came to me. Okay. Can be nausea or could be a simple palpitation. So these are three kinds of premonitory symptoms which happened with them. Now look at this name, premonitory. That means having this symptom, they guess that they're going to have a seizure. That's known as a word premonition. Premonition. Okay. Now a student came back and asked me this doubt. So why don't you write this word as aura? Now aura was a term that I left for this topic. Remember, in neurology practice, aura means something different. Aura is something that I know as hallucinations. In neurology practice, remember this, aura is something which we know as hallucinations, right? Now, hallucinations are something which can happen in any sense. Could happen in smell, olfactory, one. Could happen in taste, gustatory, two. Could happen in sound, auditory, and of course visual. So depending on the site of the hallucination, depending on the type of hallucination in the patient that happens, we can characteristically say where in the brain is the lesion actually sitting at. Now if the patient comes to me with an olfactory or maybe a gustatory hallucination, look at this. First I'll look at the olfactory. In the olfactory hallucination, the lesion is more often in the temporal region of the brain. Write this down. In gustatory hallucination, it can be parietal. In auditory, again it is temporal. And of course, the visual hallucination, the lesion is more likely to be in the occipital lobe. Correct. So depending on the site of the lesion in the brain that we have got for that particular seizure, prior to the onset, you might get some kind of hallucination which are known as aura. Now my question will be direct for you guys. Answer me this. Focal and generalized. These are the two seizure types that we find. Correct. Who is going to show me aura? Focal seizure or generalized seizure? Tell me please, F or G. Who is more likely to have aura? Focal, F or G? Generalized. Now look at this brain, look at the brain of the patient. The lesion is only located in the temporal lobe. Okay, if I draw a cross section, lesion is only in the temporal lobe. Lesion is only in the parietal lobe. Lesion can be back in the occipital lobe. Yes. So please remember, these kinds of lesions are what? Discrete kind of lesion, not diffuse. And discrete lesion results in what? Focal seizure. So don't forget this old point. Focal seizure will have aura more frequently than generalized seizure do have. We have written this down. Absence seizure, if you have written this down. Absence seizure was what? A generalized seizure. Did it have aura? No, it did not have aura. So my point here is, in a patient with GTCS, do remember this. What we find prior to the onset of the seizure is not aura. It's a sign of a premonitory symptom. A different kind of a thing that happens, which can be a simple vague non-neurological complaint like abdominal pain, nausea or palpitation. Now do remember this, after this episode of premonitory stage. In the patient of GTCS, we find the tonic phase to come in. And in the tonic phase, what really happens is the tone in the body rises. The tone of the body increases. Correct? Now tone rises and the tonic phase happens. Write this down. The tonic phase is not very long. It just lasts for 10 to 20 seconds of time. Not very long. Okay. Now tone will rise in various body parts. It could rise in the flexors of the upper limb. UL stands for the upper limb. Okay. Extensors of the lower limb. Correct. Now flexion of the upper limb and extension of the lower limb is going to result in a typical posturing pattern, which I know as a decorticate posturing. So just imagine the upper limb of the patient is flexed and the lower limb is extended. That is well known to me as a posture known as the decorticate posture. Along with this, don't forget, in the patient there is also going to be increase in the tone of the neck extensors. That means the neck of the patient is going to turn back. If the neck extensors are increasing in tone, what will happen? The neck will turn back into one direction, which is well known to me as aversive head turning. After this, remember this, in the patient, there is going to be increase in the tone of the muscles over the chest, which I know as the intercostal muscles. Correct? Also, there is going to be increase of tone in the adductors which are present on the voice box known as the larynx. Correct? Because of this, patient will often have a sound coming out very loud known as the ictal cry. Now listen to me. Just imagine the intercostal muscles are in continuous spasm. That means they are pushing on the lungs from outside and the air has to come out from there, passing through windpipe trachea, passing through a door larynx. And now the adductors on the larynx are also closed. So what will happen? At that very moment when the air comes out from the lungs, passes through a trachea on the laryngeal inlet, they are getting trapped. So under force the air has to come out. So what will happen? Listen to me. Patient will often have a very loud shrill sound like this. And this loud shrill sound is known as the ictal cry. Very commonly seen in patients of GTCs. If you have seen a patient, never forget it. And of course the air cannot come into the lungs. That will cause cyanosis. Yes. So cyanosis is another thing that we have in them. Okay. Apart from this, because the whole body is showing increase in tone, followed by a phase in which the body starts jerking, that is known as the clonic phase. Remember, this clonic phase is a typical jerky kind of a movement that we find. And in the clonic phase, it's not lasting for very long. Most of the time the duration is less than 1 minute. So we have with our patient who is shaking vigorously now, that is a clonic phase which lasts for less than 1 minute in time. And of course after this there is a phase in which the patient has got post-ictal confusion. Another phase which is showing confusion is a post-ictal phase. And of course in this very particular phase, remember this, the limb muscles are totally floppy. That means they show a lot of flaccidity and a lot of urine in the bladder will move out on its own. Urinary incontinence. So there are few points that will often happen in these patients as post-ictal confusion, flaccidity and urinary incontinence. Okay, so these are few things that we find in a GTCS patient. Okay, someone asked me to repeat the ictal cry. I'll repeat everything, don't worry. Why only ictal cry? See this. In a patient with GTCS, look at the patient. He has come to emergency room in a premonitory stage. And what are the complaints the patient is having? Abdominal pain, nausea, palpitation. And now look at your patient who tells you that now doctor do something because I'm going to throw a seizure. You look at the patient and don't understand him. You say, what nonsense? You're having abdominal pain and you're telling me you're going to have seizure. Where did you read it? Dr. Google. Now sit aside and now I'm going to give you some drug to treat your abdominal pain. You know what drug did we give? Tramadol. Suddenly when you give tramadol to this patient of abdominal pain, a patient of GTCS who has come in the premonitory stage, that moment he's going to throw a seizure now. Now after the seizure there is a tonic phase in which the upper limb stands flexed and the lower limb goes extended. That's a typical posturing known as decorticate. And the neck extensors also move back, versified turning. The intercostal muscle contract and the adductors of the larynx also contract, producing a very shrilled out sound known as ictal cry. The patient might just shout like this, that's the ictal cry, with a lot of cyanosis seen all over. And now the clonic phase occurs. That's a jerky movement. And of course, after all this thing, the patient has got a lot of post-ictal confusion. Limb muscles are flaccid, and of course, they've got urinary incontinence, right? So I cannot show urinary incontinence here. It's all prohibited, right? So look at the chronology. They say na aap chronology samajhiye. Now look at this chronology. Initially it is tonic, then it becomes what? Clonic. So that's the GTCS episode that we usually find. Okay. Apart from this, someone was asking me, sir, I've read in Harrison that absence seizure also occurs in JME. Good, you read Harrison, I'm happy. Now JME, as I told you, was juvenile age commonly affected. The word myoclonus occurred in them, which occurred on awakening as well as was precipitated by fatigue and alcohol. Don't forget this. Majority patients with JME, majority patients of JME, correct, are going to see also an episode of GTCS which I wrote earlier. And don't forget, 1/3 patients of JME are also going to have absence seizure. So someone read in Harrison, they wrote, yes sir, is this. So it's not only, see, I remember in my MBBS days, it's juvenile, many epilepsies. The M myoclonic is a misnomer because not only myoclonus occurs in them, GTCS also finds in them, and absence seizure could also be occurring in them. So it's not only myoclonus, it's GTCS and absence. All three of them could occur in a patient of JME. And taking the advantage of this kind of a thing, the examiner gave us a question. Most common presentation in a patient of juvenile myoclonic epilepsy is, answer me this please. What is the most common presentation in a patient of JME? Answer me please. What is the most common presentation in a patient of JME? You can just type the first word of it. Myoclonus, M, GTCS, G, or A absence. Majority. Everyone tells me this majority, right? Okay. No, I want to clarify this old concept. Majority and 1/3 kind of an event is not in every patient of JME. Only in untreated group of patients it happens. Remember this. Only in untreated group of patients it will be seen. Not in every patient of JME we're going to find this kind of an event. So remember this old concept. It's not GTCS, my dear friend. It's not GTCS. No, no, no. Only in untreated group we're going to have it. Myoclonus is something which happens in a patient of JME always they present with myoclonus. It's a most common presentation of JME apart from the other two seizure type that we know. You know, I still remember this old case which I recall every year in every classroom teaching that when I was very young, I was an intern. There was a neighbor of mine, a 14-year-old boy. He had a very typical problem. Listen to me, very interesting story. Every morning he used to get up, brush his teeth, and while brushing his teeth, he used to have a myoclonic jerk on awakening. yeah, brushing your teeth on awakening, and suddenly the toothbrush from his hand fell down. And he went to the breakfast table to hold a glass of milk, and the same myoclonus occurred and it fell down. He went to school, held the pen, again the same story happened. And one day, the great event, parent teacher meeting happened. And now what happened was the teacher and the parents together thought one thing, that adolescent 14-year-old boy doesn't want to study, doesn't want to drink milk, and of course, doesn't want to brush the teeth. Yeah. So, teenage problem, adolescent problem, they all neglected it. But that very morning, I remember I saw that boy in front of me having that typical myoclonic jerk. I told my neighbor, his mother, that auntie, he's having a serious problem. He said, what problem? I said, auntie, he's having epilepsy. Now, auntie looked at me and said, you know what nonsense? How do you know? When my boy is watching television in night, he never drops the remote control. Look at the event. Myoclonus, I repeat, occurs more often on awakening, not in the night. So everyone neglected my thought, and 2 years down the line, I found the same boy being treated for epilepsy. Because when we leave this untreated, they will go to a phase of GDCS and absence seizure. So don't forget this old point. And whatever I have told this 2 years back, I still remember in AIMS we got an MCQ based on it. A 14-year-old boy has come with a complaint that while morning brushing his teeth, the toothbrush from his hands fall down, and one of his family member is also epileptic. What disease are you expecting it to be? It was a very nice story and a very simple thing known as Jamie. Correct. Now, the last one in the race is temporal lobe epilepsy. Temporal lobe epilepsy. Okay. And who is this Shivam? You are all after Shivam. Temporal lobe epilepsy. I'll ask Mishra ji once about it. Who is this Shivam? Must be Deepu's friend. That's why it's very famous. Temporal lobe epilepsy. Okay, stop this. Temporal lobe epilepsy is a patient who comes to me with a focus seizure with loss of consciousness. That is, focus seizure with impaired awareness is a typical type of seizure that presents with it. Okay. Now, apart from this, do remember this, that in patients of temporal lobe epilepsy, we often find in them in the childhood days history of febrile seizure. So, history of fever and seizure in a children is well defined to us in pediatrics as febrile seizure. So, history of febrile seizure is often found in these kind of patients. Along with this, these patients do have a phenomenon which is known as déjà vu. Now, déjà vu is a term in French which basically means familiarity with unfamiliar surroundings. So, familiarity with unfamiliar surroundings is defined to us as a word déjà vu. Correct? That means something which is not known to me would be found in these patients. That means in a locality they go which they have never been earlier, that is a surrounding, and suddenly the patient feels that, yeah, I've been here earlier also, is known as the term déjà vu. Simple. Now, temporal lobe epilepsy is an epilepsy which presents with focus seizure with loss of consciousness, with a febrile seizure and a déjà vu experience. But why is it known as temporal lobe epilepsy? Because on imaging, we find in these patients enlarged temporal horn, one thing. Please do remember these findings. On imaging in these patients, we do find enlarged temporal horn, small temporal lobe, and of course we find degeneration seen in the hippocampus, that is known as the hippocampal sclerosis. So in these patients we do find hippocampal sclerosis, a small temporal lobe and an enlarged temporal horn to be seen. Okay. In patients of temporal lobe epilepsy, there's a treatment available with us is to remove the cause of the disease. For example, we can remove the temporal lobe in these patients. We can do a temporal lobectomy, removing the temporal lobe in them. Or we can remove the hippocampus part also in them. It's known as the amygdalo-hippocampectomy. So please do remember these two terms. Most of them have got treatment available. And look at them, temporal lobectomy and amygdalo-hippocampectomy are the two treatment available for patients of temporal lobe epilepsy. That means when I want to treat them, the best therapy, the treatment of choice is going to be surgery for them. Correct. And of course, that is temporal lobectomy out of the two surgeries. That means, do we remove the entire temporal lobe in them? No, my dear friend. We remove a part of it, which is known as the anteromedial part. So anteromedial part of the temporal lobe is being removed in them, and we remove a particular segment of it. So that's a surgery prescribed for them. Now look at this. The treatment of choice, being abbreviated as TOC, is not drug of choice this time. So write this also point that anti-epileptic drugs that we give for treatment in them, these patients are often resistant to it. They do not respond to the medical line of therapy, and they're more amenable to a treatment which is non-pharmacological, known as surgery. Okay. Right. Right. One more thing. Side effects of temporal lobectomy. Yeah, of course, if it's a dominant lobe, you remove the speech area, you can't have a problem with it. Nowadays, we do a functional imaging in which we perfectly find the site of the disease and accordingly we operate it. But for exam purpose, you should know, yes, we do a temporal lobectomy as a surgery and a part of it is removed, anteromedial part. Now another point, write it down. I've told you certain drugs, toxins and metabolic event resulting in various kinds of seizure. But depending on the type or maybe any type of seizure, there can be causes of seizure different in different age groups. Okay, different in different age groups. Write it down. The book says in the adolescent age, which Harrison has given as an age group of 12 to 18 years. Okay, the adolescent age of 12 to 18 years, the causes of seizure that we usually find are T, G, I, B. T stands for trauma. G stands for genetic disorders. I stands for infection. I stands again for illicit drug use. Can you tell me two drugs, illicit drug use? Okay, which can cause this kind of a problem? Two drugs, illicit drug use. I've already answered this question. And of course, the last B stands for the brain tumors. Brain tumors. Okay, in the adolescent age, we have got these kinds, yeah, cocaine and amphetamine. Right. Then we have the young adults, which you look at in the age group of 18 to 35 years of age. Now for 18 to 35 years of age, there are many causes again. T stands for trauma. Trauma. A stands for alcohol withdrawal, because they start drinking now, they stop drinking, problem. Illicit drug use again. brain tumors, and auto antibodies, right? Now we go into another age group which is known as the older adults. People above the age of 35 years, okay, are considered in Harrison as older adults. Even the elderly, they are put into this group. Now in them, remember, stroke, CVA, cerebrovascular accident happens to be the most common cause, number one again. Okay. Now the strokes are of various types. We lead them in the live classroom discussion. Remember this, embolic stroke is a stroke which is most epileptogenic, followed by the hemorrhagic stroke, followed by the thrombotic stroke. So don't forget the order. Embolic stroke are the most epileptogenic stroke anytime, hemorrhagic and then the thrombotic. Then remember this, after this we find the brain tumor. After this we find the brain tumor. After this we find alcohol withdrawal. Then we have degenerative CNS disorders. Even some degenerative CNS disorders have been known to cause seizure. Can you tell me if a degenerative seizure disorder, yes, causes seizure, what kind of seizure is most likely to happen? Will it be absence? Will it be focal? Or will it be myoclonic? Tell me please. Please tell me. Waiting for your answers. My God. I again repeat, degenerative pathology. That means somewhere you're lost in the classroom. Pay attention all the time. I've already mentioned, yes, myoclonic, myoclonic, myoclonic. If I get a myoclonic seizure, hypoxia, degeneration, and metabolic, three events happen, not focal, my dear friend. It's a myoclonic seizure more likely to happen in them. Okay. Now, after this, we have got autoantibodies. So, vasculitis kind of a disease which can be a cause for it. Now, someone asked me later on, sir, if they ask me overall, someone asked me in between also, I was just looking at the chat box. Sir, overall, most common cause of seizure, if they ask me, they don't mention any age. Please tell me what should be my best answer. Tell me, what should be your best answer if the age is not being mentioned? Common sense, apply your mind there. What do you find very common? Head injury, yes. Trauma, yes. So trauma is something which is considered to be overall the most common cause of stroke. Now write it down. Not most common cause of stroke, but seizure, please. I'm just correcting myself. It's not trauma, it's not tumor, it's trauma, trauma, trauma. Now write the small concept. Seizure risk post traumatic. Now this is something which should not be touched upon in neurosurgery. Seizure risk post traumatic. This has come recently actually, that's why I'm highlighting this point. High risk. There's a very high risk of seizure post traumatic, right? That means there is a risk of 30 to 50% to happen seizure, if at all. If at all, it's a penetrating head trauma. If it is a penetrating head trauma, correct? If at all, it is a depressed skull fracture. Thirdly, if it's an intracranial hemorrhage, or maybe it's a gajni. What is gajni? Prolonged post traumatic amnesia. When the lockdown opens up, I'll also suffer with this because I will never know where I was working in. Okay, I'll become that Singhania. Okay, so penetrating head trauma, depressed skull fracture, intracranial hemorrhage, post traumatic prolonged amnesia is a high risk for having seizure after head injury. Now, please remember this also. What are the factors which happen to be a moderate risk? Moderate risk for seizure to happen. First of all, closed head injury. That means it's not a skull fracture, neither it's a penetrating trauma, it's a closed head injury. And secondly, cerebral contusion. Cerebral contusion. So after a cerebral contusion or a closed head injury, there is again in this, and around 5 to 25% of patients with a cerebral contusion or a closed head injury can have a seizure later on. So it's a moderate risk. And write this down. Low risk for seizure, post traumatic, mild head injury, and amnesia or LOC less than equal to 30 minutes. So two factors which can be a low risk for head injury. Why I'm telling all this story? Because these are the questions which are being framed like this. A patient of head injury comes to you and he's having amnesia and loss of consciousness for a very short duration, and there is some scalp laceration only. Is it a candidate for a seizure disorder to be later on? No, it's a low risk for it. While a patient with a depressed skull fracture or dent onto the skull is obviously a higher risk, okay, compared to this one. Right. See, if you want to write the notes, don't look at the chat box. I'll tell you one quick clue for this. If you start looking at the chat box, you'll go mad. Okay. So it's a Ramayan time, someone is telling me. Okay, let's see what happens in Ramayan today. Right. And some doubts from your end, because we are now at 9:04. Okay. Any doubt? Any doubts? Most welcome. You'll get 9 minutes at 9 p.m. to show your doubts. Yeah. Manik Gill has asked a genuine doubt. Sir, temporal lobe epilepsy should be coming under focal seizure? Yes. Temporal lobe epilepsy is a type of a focal seizure episode which comes to me with a history of deja vu. Someone was asking me deja vu also. Deja vu means familiarity to the unfamiliar surroundings. That means I've been to a place not earlier, yes, but I find myself familiar to that place. That's known as the deja vu. Okay. Yeah, in absence seizure, we have got loss of consciousness, contact. Yes, it's a generalized seizure. See, LOC can be used for classification of focal. But in absence seizure, to define it every time, we have to have a definition. That means the patient is physically present and mentally absent. Loss of consciousness, yes, is something seen with them. Oh my God, you are typing doubts. My God, you cannot hold the right. So many doubts. Oh my God. Let me hold the doubts at least once. See, Lennox-Gastaut syndrome, someone who's persistently asking me that doubt, that will be dealt in peds beta, because in peds you have to read some syndromes which are perinatal, so it comes over there. So I'm skipping that topic. Loss of consciousness in GTCS, yes, it will be seen. Whenever we find these patients in the post-ictal phase, we find an LOC with them. Okay, I think so. If you keep on typing on doubts like this, it will not only give me vertical nystagmus, it will create seizure, because your doubts are provoking seizure in me. Uh, so before we get seizure, I'll post all the. I'll put up a post on Facebook, on FB club. We'll keep it as 2020 wala. Okay, let it be only in one club. That's better. Let's go to this club and we'll try to solve the doubts. And please, 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 read and above all revise. Because tomorrow when you come, tomorrow, I'm going to give you some set of MCQ questions which we are going to solve together, and I'm going to give you some videos also, and we're going to diagnose some kind of seizure disorders that we have, and of course we'll be dealing with the most important part, that is the treatment part, right? So just to end the show, a joke. Yeah, joke is always necessary and compulsory. When the student looks at their watch, I don't mind. But those students who look at their watch and remove it and start shaking it, I mind them, because I think they are thinking in this way: the time is not moving or this teacher is not moving. Okay, right. Chalo, ciao, good night.